Good evening, colleagues, and welcome to our weekly Clinix webinars where we discuss various topics presented by different speakers from across the health spectrum. And the past few weeks, last 2 weeks and this evening, we are constantly mainly on NHI, National Health Insurance. This is the last episode of the three-part series that we've been having. And just before we go into that, we just want to thank you for joining us once more at these webinars. Some of you have been with us for the last 2.5 years or so. And please note that these webinars are CPD accredited. And so when you log in, please do provide us with your full details, your HPCSA registration number or nursing council, pharmacy council, whatever body that you're registered with, so that we are able to upload your CPD points at the end of the presentation that will be sent to you directly from the HPCSA. And also note that these webinars are live streamed on YouTube. So at the end of the presentation, you're able to go back and watch the presentations. This evening, the format is a bit different. We have a panel discussion. And some of the speakers will do presentations and some will just be speaking from the heart. But do please take notes, and then at the end of the presentations, we'll also have a time of Q&A. So we have 3 speakers who will do the presentations. And the topic that we're covering this evening is national health insurance implications for the healthcare professional, departmental and regulators' responses to the health service providers or healthcare professionals' concerns. So we've got the HPCSA, we've got from the Department of Health, and then also from BHF. This webinar for the last 3 weeks have been presented jointly by Clinix Health Group, BHF, Board of Healthcare Funders, and Health Matrix, represented by Dr. Pino Mabengere. So I'm going to hand over to him to do the introduction of this first speaker. There will be Dr. Rajesh Patel, followed by Dr. Mahumi Masike, and then Professor Nicholas Crisp. Pino?
Thank you very much, Ray. And again, welcome to everyone to what really I think are very essential discussions against an issue we face, which we have to face. The issue of NHI, which is upon us, it's a part of government policy. So the idea is to look at the impact specifically for the healthcare professionals, the healthcare providers. We had the week before and last week discussions on that. So we were fortunate to have, sorry, we can just list, if we can mute. All right. Okay, thank you very much. So we are fortunate to have a panel today which really represents a spectrum of people with interest and knowledge about the industry. So we have an opportunity to ask questions. So please, as they speak, and also from the last 2 webinars, if you got questions, please post them in the chat box or the question box and send them. Behind the scenes. We'll try to collate the questions. And then we'll also have the speakers from the industry speak. We'll start with Dr. Rajesh Patel, who we know most. As you know, he's a registered practitioner with HPSA and has been practicing as a specialist family physician for more than 37 years. And he's head of the Health System Strengthening Department at the BHF. He advises the board on healthcare policy, medical scheme benefits, healthcare quality and affordability. And his career includes really a lot of things. He has been a GP, a family physician from 1988 to 95. He has left private practice, went into healthcare administration, advising schemes, and then served as a medical advisor then. And then, of course, you have BHF, which is an association of funders and administrators. So it has a perspective which is very interesting to listen to. And then we'll introduce as well Dr. Mahumi Masike when they come in, and also Prof. Nicholas Crisp as they come in. Dr. Raj, it's your turn. Rajesh, are you good?
You're muted.
Been muted. Oh, there we go. I've been unmuted now. Let me just try to change this. And I wonder, how do I change this bit here? Okay. some of the other, I've got a problem. Okay. Let me know if you can see the full slide. Has it come through?
Yeah, it's
Yes,
fine.
Yes, we can see it though.
Great stuff. Thanks a lot. Thank you very much again for this invitation, and greetings to my panel colleagues. That's the registrar from HPCSA, Dr. Masike, and Professor Nicholas Crisp as well. Well, it was good to be this evening. I've been asked to sort of provide the summary of some of the problems that have been identified for health service providers. And hopefully during this engagement kind of thing, we can try to address some of these things, clarify some of the questions, etc., that might have come up in the past. So very simply, if you look at some of these numbers that were prepared a few years ago, literally NHI will not be able to be implemented successfully without private sector providers participating in the NHI arrangement. If private sector providers are sidelined or not necessarily brought into the fold, it's going to be a long haul for the NHI to be successful. And I think that's an important consideration, that private sector providers are important in the health system. Clearly, what are the major issues that we're going to talk about? I think the one biggest one that comes to mind is the proposed medical scheme amendment that literally unfairly discriminates against pregnant women. And if the president proclaims the medical scheme amendment before medical scheme members actually join NHI, then they're going to be absolutely out of pocket of anything between.
Wait, your speaker is not working. Please check your connection or use a different speaker. So I cannot hear.
Sorry. I was saying that if the president signs the medical scheme amendment, proclaims the medical scheme amendment before medical scheme members onto the NHI, literally those pregnant ladies, if they go to the private sector, they will be paying cash because of the changes in the complementary cover arrangement. And also if they go to the public sector, they're going to have to pay cash, literally because there's a provision in the National Health Act.
Your speaker is not working. Please check your connection.
Sorry about that.
We can hear you. You have a problem. Please don't disturb the proceedings. We can hear you. We can hear you very well. Please, otherwise, if you keep on interfering, please.
Okay. As I was saying that the pregnant women will have to pay for services either in the private sector or public sector for cash, literally because there's a provision in the National Health Act, I think it's Section 4 or something, which says that maternity services and child health services is free for everyone, except for those belonging to medical schemes. So even if complementary cover was included, pregnant women who are on medical scheme would still be classified as on medical scheme and therefore potentially have to pay cash for those services. I think the other important issue is the whole issue of accreditation, the contracting issues, etc. We'll talk about it. Then there's some components about reimbursements in the legislation. There's about 5 pages full. I'm not sure why there's so much of it in legislation, because most of it should actually belong to regulations. I think there were some issues after the meeting. There were some issues raised about quality of care monitoring, and I'll pose some of those questions and raise some of those problems that were brought to my attention after the meeting. And thanks for forwarding some of those questions through to me. There's a problem here. Okay. I don't know how to hide this one component here. Let's do that. There we go. I seem to have success now. So in the whole contracting process, obviously the professionals will need to have their HPCSA certification. And I guess that one of the first criteria would be to check whether they are paid up members or they paid up with a regulatory body like HPCSA. There are 2 steps following that. The one is called the Office of Health Standards Certification, because practitioners work at the facility or their rooms are their facility. And in the legislation, or should I say in the bill, it's written that following that, there'll be accreditation by the NHI. Now, obviously, There's a combination of issues here, and perhaps Nicholas can clarify these two, what it's all about. Before you can even be eligible for a contract in terms of the Public Finance Management Act, professionals will have to register with Treasury and be listed as a service provider on their provision site. I think that for most people in the private sector, this process would be Greek. They'd probably not be familiar. And perhaps maybe what would be required is more guidance to the profession as to how they can go about, once they've got their Office of Health Standard certification, their accreditation, how do they then go about registering on the Treasury website? The last component obviously would then be contracting, but in fact, that's probably the most important before you even start this whole process. And issue is, what is on offer? Because if the offer is great, people will want to participate in this process and will go through the accreditation, etc. If the offer on the table is not that great, people might be very reluctant to go through this whole accreditation process. So I think that contract is absolutely important. We know that Department of Health has been working on a lot of the NHI implementation issues, etc. And if there is a draft of this contracting available, a kind of a template or so, it would be great if it's available to everybody so people can familiarize themselves with it. The representative bodies can look into it, identify any issues, and obviously engage with Department of Health on it. The big question is, will the practitioner in the street require lawyers to evaluate this contract and then obviously decide whether he wants to sign it or not sign it? And I think that's an important question that we need to ask. Lawyers obviously can make contracts very complicated, and the simpler it is for providers, the better it is. I think if you look at the whole process, there's obviously a lot of costs that are going to be involved, where you have Office of Health Standard Compliance certifications, etc., accreditation by the NHI. The question then arises for the provider is, what is the cost of the facility accreditation? And I think that would be also determined where the providers do or don't participate in the whole contracting issue. There's also an important function or activity called user registration, and this would probably be starting off at the primary care level. The big question is, are all accredited providers, particularly accredited for service delivery, expected to do this function? And obviously that would indicate whether providers have to have additional resources, staffing, etc. And we'll talk about that in a moment. It talks about that to register users, you need to be accredited, but it's not specific about the kind of accreditation. Is it accreditation for service provision, or because this is a registration process, that you need a separate type of accreditation as it relates to, you might have the resources, systems, the training, etc., to do the registration. So I think clarity is required here, and obviously the bill is silent on that component, whether it's a separate accreditation process. We generally see that if this additional accreditation is required, that would probably be seen as an additional hurdle for providers. And I assume that potentially the accreditation they refer to here is the service provision accreditation. Now, I'm sure Nicholas will clarify that. But I think even with regards to user registration, there's going to be an additional cost component for the practitioners or the providers of service, and definitely the providers would be looking at some kind of cost recovery. The first question to be asked, is the user registration not an NHI competency? One don't go to the post office kind of thing if you want to register for SASSA. You say register with SASSA type of thing directly, and then you can get access to your benefits at the post office or the banks or whatever else. Definitely, this user registration is not something the professionals are doing right now, or practitioners or practices are doing right now. And therefore, if they do have to undertake this exercise, it potentially might mean additional staff, some system amendments, some system changes, some training that they might need to undergo. There might be costs related to training. For example, if the training is held in central places, the provider in the outlying areas have to travel there, or their staff have to travel, etc. So there are real cost implications, and definitely this is obviously a lot of questions. It raises a lot of questions. I think there's some additional questions that come through as it relates to what might eventually be on the contract, and that is the health service provider revenue in total. If one looks at it, they earn scheme rates at the moment. Some people are charging above scheme rates for those that are dealing with medical schemes. COIDA, if I recall from some time ago and from my days when I was in practice, their fee structure is about 50% higher than the medical scheme. So if all of this is now taken up under the NHI, potentially the providers might experience reduced fee levels. And while this may be compensated by the greater numbers of beneficiaries linked to that practice and the NHI contract, the question still remains, what would be that fee level that providers will get, and to what extent is their revenue affected, and to what extent will they influence their decisions in participating in the whole process. Naturally, it's been communicated quite extensively that there'll be greater use of alternate reimbursement models. To get that finalized, obviously, there will need to be a lot of consultation with health service providers. The question is, to date, obviously in context of some primary care practitioners or whichever other professionals that are out there, who has been consulted? Has the process started, or is the process still to be started? When do we expect that to kick off, etc.? So I think some information on that would be very useful. I know some time ago, Department of Health and Treasury had started some research project on capitation. I believe that research was completed and the results was made available. I haven't necessarily seen it, but I have heard some practitioners talking about communication in that regard. The question is, if there was that work, can that figures sort of be inflation adjusted and give us a sense of what the value looks like at this point in time? That would obviously inform many of the practitioners, particularly the primary care practitioners, as to what they might be looking at on a per capita basis. Then complementary cover obviously raises certain issues with regards to private practice and providers of service in private practice. So with complementary cover, the role of medical scheme is going to be minimal. At this point in time, medical schemes obviously major funders of private sector providers. So if the scheme role is sort of minimized, that would potentially reduce their revenue significantly. And to some extent, depending on whether they don't contract to NHI, etc., there's a potential to decimate the private sector service provision environment. And I think critical is that if we want to make NHI implementation successful, it is important to retain and strengthen the private service provision environment. We don't want to be decimating that. We don't want to be threatening that. And yes, there's lots of room in South Africa. There's no need for people to even threaten about wanting to leave the country. And I don't think that's absolutely necessary. The question is obviously the revenue that comes in from NHI and contracts with the NHI must be of a sustainable nature for those practices, and therefore need to be talking about not just a couple of patients in the practice. Potentially there needs to be a bigger number of patients that would need to come to those practices to make sure it's sustainable. But it will be dependent on the amount that they get in remuneration. There's always this talk about new coding details kind of thing. Perhaps that can be perhaps Nicholas can tell us a little bit about that. What are the new coding structures, etc., envisaged? And is there any announcements that's going to come through anytime soon? There's also been some questions, and these came through a little bit later, is the quality of, how is quality of care going to be assessed in a capitated type of environment? How does this influence the structure of the performance-based reimbursement? Important question for the HPCSA, whose main role is supposed to be protecting the public. How will the HPCSA proactively monitor quality, protect the public? At this point in time, there's a lot of litigation that's going out there, and particularly negatively affecting the public sector, and it's just increasing exponentially. That is a major threat to the health system generally and to the funding of the health system. And therefore, it's important that we get on top of it. If there are quality issues that are a problem, we need to make sure we plug that hole as soon as possible. A comment has been made quite often, and people often refer to this, is there public sector corruption and delinquency that's often there to pay service providers. For example, the Road Accident Fund stretches payments out and sometimes people don't even get paid. We've heard about the newspaper articles, etc., about food shortages, providers not being paid, equipment maintenance organizations not being paid. And the question then arises, how will this be different going into an NHI environment? Will there be this kind of delay in payment, etc.? How will the creation of CUPC, the CUPS and the District Health Management Office be different from what we see around at the moment? We know that in the National Health Act, there's provision being made for District Health Authority, and this was signed off in 2003. We are now in 2023, and literally there's no real District Health Authorities in place. So how can we be certain that practices will get paid? If we look at the NSFAS scenarios at the moment, created, they got a third party involved, and guess what? There isn't real payments flowing through to the students, etc. Obviously, this creates some fear, and it's critical in this process that we build some trust, Nicholas. Obviously, I know you need to do a lot more roadshows, and particularly with the providers. Many providers have been telling us is that no one is engaging with them. And I think this is an absolutely critical area that needs to be addressed. And we need to start building that trust, or demonstrate trust, and demonstrate that the departments of health in not just the national, but also the provinces are getting on top of corruption. Otherwise, there won't be any faith in the management of NHI. I think in summary, I don't think there's a problem with universal healthcare coverage. I think everyone supports it. Everyone sort of supports the idea of NHI as a reform tool. But I think the big problem is the content of the bill and how it's worded. And I think not many people are confident that the content of this bill is fit for purpose to be able to achieve, the drive towards universal healthcare coverage. And a major component, as I alluded to earlier, is the trust in government. If we address that, I think we'll make significant progress in NHI. Chair, with that, I'll say thank you. And I'm not sure now. Oh, there we go. Cool. Okay, Ray, you're still muted.
Thanks, Raj. I think Ray is coming.
No, that's right. Go ahead. Yeah. Thanks, Rajesh. You can do the next speaker,
Sure. Thank you. Yeah. Thanks very much, Rajesh, for Dr. Patel, for highlighting some issues which come with the development that is happening. And I'm sure the speakers and also as the audience are taking note of that. So we'd like now to welcome Dr. Mahume Masike, as we know, and congratulations, Dr. Masike was appointed this year as the head of HPCSA. He's somebody I know quite well. He has been in the healthcare sector for quite a long time. From 2010 to 2018, he was MEC of Health. And then he also holds an MBCHB and master's degree, as we know. And he also was president of SAMA in the Northwest and a member of the provincial legislature in the same province, and also a portfolio committee for finance of the Office of the Premier. So one could see that he really is aware of the public sector and private sector issues. He boasts a wealth of knowledge in the private and public sector with extensive experience, especially in leadership and governance. He's also not a stranger to HPCSA, having served as the chairperson of the Undesirable Business Practice Committee and as a member of the Audit Committee. But now he has the institution. We'd like to welcome you, Dr. Masike. If you may also just address for us the regulator side of things. Dr. Masike.
Thank you very much, Pino. I'm glad that you didn't say how you know me. Ladies and gentlemen, let me start by saying that the South African government under President Cyril Ramaphosa is working to introduce the national health insurance. This is necessary to address the problems faced by the current system, which is not working efficiently. I think BHF has demonstrated to us that what we've got now is not working properly. The South African National Assembly passed the National Health Insurance Bill, which will now be directed to the National Council of Provinces for passing. Once passed, it will be signed into law by the President of the Republic. This is a process that may take a little bit of time. The provision of universal access to healthcare has long been envisioned, not only by the Constitution of the Republic of South Africa, which states in Section 27 that everyone has the right to access to healthcare, but also to the National Health Act of 2003. Now, the National Health Insurance is undoubtedly going to be with us and be upon us very soon. There's no doubt about it. There's no doubt that the bill is going to be signed. I hope I'm right. Now, as the Health Professionals Council of South Africa, from a regulatory point of view, we have identified our role, and we are putting an investment into making sure that we are able to assist in giving information, well, data that must become information ultimately. We believe that we are best placed to say, for instance, with the Department of Health, how many radiologists do we have and where are they? How many oncologists are we having and where are they? You know, so we believe that we should be able to make sure that the importance of demographic data, the importance of clinical data, and the importance of genomics is consolidated to the extent that we inform the department to be able to take managerial decisions as far as the national health insurance is concerned. What are the tools of regulations that we think will apply in the future? Norms and standards, registers, discipline, education, community engagement, research, and what are the health effects of the regulatory process? I want to quote a doctor. You know, we had a presentation from the Medical Protection Society, and this is one of the quotes they gave to us. One of the doctors said, the health effects of regulatory process. Every time I see my lawyer's name, every time I get a call from my lawyer, I get palpitations. Now, given the future of healthcare in our country, the Health Professions Council of South Africa says to you tonight,
look,
what will change?
Just move your face a little bit
What
to
will
the
change?
left. We can't see your face.
Come again?
I want to see your face.
You can't see me. Okay.
Yeah. Dr.
Well,
Masika
I'm
is
looking
not
from
sharing
another
the
laptop.
presentation. So
Okay. Can you see me now?
I can see very well, yeah.
Good. What will change is a range of regulatory styles. We believe that we've got to change from enforcement to complementary assessment. We believe that we've got to change from being reactive to prevention. We believe that we've got to change from being adversarial to a partnership. We believe that we've got to change from being incident-driven to problem solving. We actually believe that we've got to change from being hard to soft. Regulation does not just rely on new laws. It's about norms and standards. It's about structures of ownership. It's about compliance, assistance, and oversight mechanisms. And all this needs to be integrated, and the public needs to buy into it. As a regulator of the health professions, the HPSA will do everything in its power to ensure that our registered practitioners are ready and equipped to roll out the new NHI with appropriate skills and competence. Where possible, we will ensure that we will align our CPD programs to ensure that registered practitioners are provided with adequate skills and knowledge, which will enable them to constructively contribute to the effective and successful implementation of the national health insurance. Now, many years ago, as early as 1985, we defined what we believe will be the national health system. Now we're talking insurance. We believe that it has to be a state-mandated, state-managed system of healthcare financing that is free at the point of care. So the idea of this health system, which towards development of this universal healthcare, was developed many years ago. We can go into the history, but during our student activism, this is what we said. We said it in 1985. We're still saying it today. Thank you very much, Chair.
I believe you can go ahead and introduce Professor.
Sure. Yeah. No. Thank you very much, Dr. Masike. Yeah, we really appreciate you being available on short notice. I should have I highlighted the people you came from abroad just recently, in fact, so you don't have slides, but we're speaking from your notes. So apologies to the audience. We should have highlighted that, but you just agreed to try and give us the first, the healthcare regulator, healthcare professionals regulator's perspective on NHI. And as usual, we would like to have questions if we have to pose to him in the background, and then we'll just try and collate that. That takes us, if you don't mind, colleagues, so that we can catch up with our time, to Professor Nicholas Crisp, who is well known to most of us, I'm sure. He's a medical doctor and a public health specialist who has for many years focused on healthcare management consulting the African continent. And he was also previously superintendent of the Department of Health and Welfare in Limpopo, where he served in 1995 to 1999. So quite a bit of public service there. And then he was also very much intimately involved in the establishment of the NHLS, the National Health Laboratory Service of Africa, mortuaries for the police, to help and create the forensic pathology services, and also in the establishment of the South African Health Regulatory Authority, or SAPRA as we know it. But I'm sure you are well known now for your role with the NHI. So I'd like you to please just present to us the departmental perspective, especially having heard what the regulator said, and also what Dr. Rajesh Patel said, almost representing the private care sector side of things. And then we'll be looking out for questions to ask you, Dr. Crisp. But thank you so much for availing yourself. I know you're also on the road and very busy, but we appreciate your presence. Thank you very much. Dr. Crisp.
Thanks, Pina. Thanks very much. And before I get into the evening, let me also say I don't have slides. This is my third conference today, and yesterday I was in East London at another one, so I don't prepare slides for every single presentation, but I'm more than happy to first of all outline a whole lot of changes and things that are happening with the NHI, and then to take questions. So the first point is that the National Health Insurance Bill was presented day before yesterday in the National Council of Provinces, in the Select Committee, and 8 of the 9 provinces presented their mandating authorities, all in favor of the bill. Tomorrow, the Western Cape will present their mandating position, and on Tuesday next week, the National Council of Provinces will vote on their mandates. So we anticipate that it will be an 8-to-1 vote next week, and that means that the National Council of Provinces will refer the bill to the President to assent to the law, and that means the President can sign it into an act. What happens after that is that the president can then be requested by the minister, who's the responsible authority in terms of the Section 92 of the Constitution, to implement or authorize that certain sections of the bill be brought into law. It will not all happen at once. I will clarify some of the questions that Rajesh asked during the presentation so that you can understand some of the time frame that's anticipated. So what will happen, of course, is that the National Department of Health does not make decisions on the national health insurance. There must be a board that is created that is given the authority in terms of the law to manage and provide be the accounting authority for the fund. And until that board is appointed, the National Department of Health has no role to play in presenting anything in terms of the national health insurance. What we are doing at the moment in my branch is to prepare some of the administrative matters that we will present to a board once it's appointed. So what's going to happen is that we will request the minister to ask the president to bring into law sections 12 to 30, which will enable the minister then to embark on the process of recruiting a board, and the board to appoint the minister will appoint a chairperson with the approval of cabinet, and then for the board to appoint board committees and the minister to appoint advisory committees. We anticipate that that process will take anything from 6 to 9 or even 12 months, because the minister is required to publish the regulations in the Gazette for public comment for a minimum of 3 months. And then hopefully you will all comment on those regulations, and we will incorporate the regulations. And then the minister can set about appointing an ad hoc committee, advertising for people to be nominated to the board, and going about the process that is outlined in the sections of the bill. It's a fairly lengthy process. The minister merely signs at the end of it. It is not decided on by the minister alone. And that process, if we get our way with the regulations, will be entirely in the public domain. And the interviews of the candidates for the board will be done in the public domain on some kind of a TV channel so that everybody can witness those interviews. Even the selection of the ad hoc panel, which the minister is required to appoint, even the process of nominations, which hopefully you will nominate people to be on the board, will all be done in an absolutely transparent way. So we cannot anticipate that anything will happen with the publication of processes of the NHI fund until the board is appointed and the board has decided whether those are the processes that they want to pursue. This is not a matter for the Department of Health, and it's not a matter for the minister. And I hope everybody is very clear that the bill says that this will be an autonomous body under Schedule 3A of the Public Finance Management Act, which is governed by Chapter 6 and all the sections of Chapter 6 of the Public Finance Management Act. So for those who are not familiar with that, this is not something the minister is really able to interfere with. It is an autonomous body that does it. So please don't expect a massive and big changes after next week, Tuesday, when the bill is adopted by the National Council of Provinces. There's still quite a substantial process that needs to be followed before anything substantial happens. Having said that, the bill provides a framework. It does not provide the details of how anything is going to work. That is how all our laws work. If you look at the National Health Act, you will see that the current National Health Act, sorry, I must apologize if there's a lot of noise in the background. I could see that I would not make it to my destination by the time I needed to be on this webinar. So I pulled over and found a restaurant where they've kindly allowed me to talk. So there's a lot of noise about the cricket at the moment. So to get back to national health insurance, this is quite a long journey that we are going to follow, and we will not be rushed into anything. We will not have any money in the National Health Insurance Fund for another 2 years at least. We will not even have a board to manage that, and nor a bank account for the National Health Insurance Fund for at least another 2 years. So people can all relax. There will be plenty of chance for engagement on the many issues that have been raised. So let me indicate and go through some of the very important and deliberate questions that Rajesh has asked. And I don't have all the answers because I'm not the board, but clearly we will advise a board when it is appointed. Hopefully I will still be around for that at that time, even though I'm getting a bit close to retirement now. I envisage I will still be around to brief them on the details that we have prepared. So let's go through some of those things. Number one, the bill is absolutely clear that all public and private providers are required. So that was the first point that Rajesh raised, and there's no question about that. The bill requires that the fund must engage all public and private providers. Of course, the question is how are we going to do that? Let me go to the question of out-of-pocket payment and pregnant women and so on. Rajesh will have to take me through the details of that. The law is very clear. All pregnant women, all breastfeeding women, and all children will be covered, irrespective of whether they are legally in the country or not. The fund must pay for their health care, and that is a requirement in the bill. And if there are some conflicts in anything that is in the wording of any of the schedules, I'm sure we have plenty of time to fix that before that is brought into law. Remember that the president will not bring the entire bill into law when he signs it into law. We will only ask for sections 12 to 30 to be brought into law in the first year. And until there's a board, there's no point in bringing anything else into law, because there'll be no budget, there'll be no administration, there'll be nothing with which to administer this fund. In terms of the accreditation story, so let's understand, first of all, that the intention is to simplify everything. It is not intended to complicate things. So the work that the preparatory work that we are doing in the department, which we will not publish because it will have to be presented to the board, and the board will publish it for comment. And the board will engage with the various stakeholders through the mechanisms that are provided for in the legislation. But in terms of that process, certification is prescribed in the National Health Act through the amendment to the National Health Act that established the Office of Health Standards Compliance. None of that is amended or changed in any way by the National Health Insurance Bill. And when it becomes an act, the National Health Act will remain the law, and it will continue to be the law that prescribes the functions of the National Health, of the Office of Health Standards Compliance. So all the work that the Office of Health Standards Compliance is doing on certification of standards is a matter that has got pretty much nothing to do with the National Health Insurance, except that the National Health Insurance is required to request a certification of what the of what has been adjudicated by the Office of Health Standards Compliance. Now, the National Health Insurance, what we will recommend to the board when the time comes, is that since there are over 55,000 establishments already registered on the Master Health Facility list of the National Health Insurance branch, which is in the Department of Health, those 55,000 establishments cannot all be accredited at the same time. And sorry, I'm being distracted by all the questions. I'll try and get to some of them just now. What will happen is that the fund will recommend to the board a period of let's call it grandparenting or grandfathering, to ensure that there's a smooth transition through the transition period. So if you take time to go to section 57 of the bill, you will see the first 3 years are entirely intended for setting up the administration of the fund, and it's only after 2026 that the fund will have any money at all and may begin to purchase health services. and it will do so in a prescribed manner at that point. And it's not intended to only purchase from the public sector or the private sector, but to purchase from both sectors. And it will need to put the mechanisms in place to be able to do that during the evolution of the first 3 years. And if there's a need to adapt legislation to do so, it can do so. So there's no need to be intimidated. The accreditation of providers is very straightforward. If you are unable to get certified by the health standards compliance now, you should be ashamed of yourselves, because it is so simple. It is, I see I'm abdicating my responsibilities, Siva. We'll come to that in a moment. We will be able to, you should be able to, unless you are not tax compliant and you're operating out of your garage illegally and not registered with the office of, with the HPCSA, you should really easily be able to get certified by the Office of Health Standards Compliance. To get accredited by the department, it's the same kind of thing that you get accredited by 71 medical schemes at the moment. No medical scheme will pay you if they don't know about you. If they are not registered and somehow connected to the systems and the switches that allow you to be paid by a medical aid, you won't be paid. So it's exactly the same that is envisaged with accreditation. The difference is, of course, is that accreditation is of the establishment, and the establishment is defined in the Health Act, not in the NHI bill, and it is the authority or the facility and the services within which we practice as individuals, whether we are in individual practice or whether we are group practice, whether we are pharmacy, whether we are an optometrist, or whether we are a very big hospital like Chris Hani Baragwanath, we are an establishment according to the law. And according to the law, the head of an establishment is required to do certain things. If you go to Section 17 of the Health Act, you will see what you are required to do in terms of keeping of records. And if you are not able to keep the records of your patients, you won't get certified. But I don't know many practitioners who would really have a problem with that. So I'm not envisaging that anybody is going to have a problem getting certified to deliver health services. Accreditation will depend on where you are practicing and what you are doing. So what is envisaged in the primary healthcare space is that we want to see more multidisciplinary teams, which is pretty much the practice around the world. That will require that we work together with our colleagues in the office in HPCSA and in the SANC and in the Pharmacy Council and so on, to see how we go about amending the various current provisions that prevent those kinds of collaborations and joint practices. But we have 3 years within which to do that after the establishment of the National Health Insurance. So I don't think you should be intimidated or in any way envisage that you are going to be victimized or not allowed to practice. You will, of course, need to be connected to the NHI digital system. It takes all of 5 minutes for that to happen. You do not need sophisticated infrastructure. We have already, since 2014, published the interoperability requirements, and since 2021, the new interoperability requirements. So if you've been able to see the gazette on these, you shouldn't find it very difficult at all to see how the protocols work. And they're mostly to protect the patient's records and the way in which we transfer the information between practitioners so that patients are not vulnerable. But there's nothing intimidating about any of these accreditation. This is not the Office of Health Standards Compliance. This is remember, OHSC is only responsible for certification of standards. The National Health Insurance is going to pay you. And if we're going to pay you, then the fund needs to make sure that you actually exist, that you have met the quality standards, that you're connected to the digital system, and that every practitioner who is allegedly seeing a patient in your practice is registered with one or other of the professional councils. So the National Health Insurance System will be live connected to all the professional councils so that we can, on any day, see who is authorized to claim for whichever scope of practice you are seeing. It should not be a worry of yours as a practitioner. We are working with the National Treasury, believe it or not, even though the public will tell you we are not, we do. We work with the Chief Procurement Officer. Remember that National Treasury has a lot of different units. There are 11 Deputy Directors General, that's double the number of the Health Department. There are 11 Deputy Directors General, and we work with several of them for different things, including the Chief Procurement Officer, to make sure that what we are intending to happen in terms of this law, both in terms of the procurement of goods and what we call health products in the bill, comply with various pieces of legislation, and the way in which we want to purchase healthcare services from providers is not obstructed by the Public Finance Management Act. So I don't think you need to be worried about that. There will be separate cover to make sure that that is not an obstacle. So the cost of accreditation is probably going to cost you maybe 10 or 15 Rand, depending on how much time you're going to take to register yourself with the Master Health Facility List. So it's really not something that we are looking at as a major exercise. During COVID, some 15,000 pharmacies registered on the Master Health Facility List, most of them in the space of 2 or 3 weeks. And it was a very easy process, mostly because they're extremely organized and they were verified by the Pharmacy Council. So my advice to practitioners, especially the general practitioners who didn't get registered very easily on the Master Health Facility List, is because we were not able to verify those practices actually exist. And we would really like to see that practitioners organize themselves better. We will work with practitioner groups to make sure that that happens in the coming years. It's really not an expensive exercise. As far as you will not see a contract from the NDIH, because the NDIH has no authority to issue contracts. Only the fund will have authority to issue contracts. That doesn't mean that we won't be working in pilots to develop recommendations that we will make to the fund, but it's the fund that will have these contracts, not the Department of Health. So we have no right, no authority, and no legal mandate to discuss any form of contracts with anybody at this stage. So it's premature for you to be too concerned about that. In terms of user registration, the average user registration takes less than 5 minutes. So if you registered for a vaccine during COVID, you will know how long it takes to register with the HPRS. In fact, it took double the time because we asked patients to tell us some more information about their health conditions. That's not a requirement, but it was done during COVID. It's very quick, very easy. You do it once, and once you are registered anywhere on the HPRS, you have a number for the rest of your life. What we will be doing is introducing a biometric technology, and we are working on how to provide that technology. So at the moment, it's already implemented in well over 3,500 public health facilities, and we will move during the course of the coming financial year to implement in our proof of concept primary healthcare environment clinics for all private providers who wish to be part of that phase of our implementation. The cost of training, well, if you are as smart as I am, it should take about 5 minutes to understand how the registration of a user works. And we were able to do 27,000 people registered as vaccinators in the space of 1 week during COVID. So it really is not an onerous process. It's very, very simple. It's a very simple system to use. And I'm sure your receptionists who already open files for patients will have no problem whatsoever going on to the HPRS and registering a patient. In terms of revenue and rates, we are very far from revenues and rates. It very much depends on the phase of the implementation of the NHI. Everybody seems to think it's going to happen next year. It can't happen next year because there's no board yet and there's no budget. There's no bank accounts, there's no system, there's nothing in place yet. So it will still take some time. And we will definitely be working with all the service providers in the space. But having said that, the fund would be crazy to adopt rates that are so low that we chase professionals away. But of course, there are providers at the moment who charge ridiculous fees, 6 and 7 and even 8 times medical scheme tariffs. That's not going to work because the fund will never pay that kind of amount to selected practitioners. There will be set fees, obviously. And in fact, on the 5th of December, we already have a meeting with the Competition Commission to begin to reintroduce what was done in the past and was recommended in the Health Market Inquiry, the multilateral negotiating forum. So years before the NHI starts to implement fixed rates, you will already experience that we are going to start to fix rates under the provisions of the Medical Schemes Act and the provisions of the competition laws. In primary healthcare, there will be a capitation payments, and we are definitely working on what that would look like in South Africa. It's a complicated space because of the nature of our country, and we will make recommendations to the board once it's appointed. And so in the meantime, what we will be doing is looking at the 9 proof of concept capitation units, 1 in each province, to see whether what we are looking at is in fact practicable. So who's been consulted? Has the process started? Yes, the practitioners who work in these 9 contracting units have all been consulted. Those who are linked into the process, and those who we are trying to entice to be linked into the process will be the guinea pigs in it, but it will be some time, and I'm talking years before this is implemented in any serious way. I personally have never seen any work done by Treasury, so I'm sure Rajesh will share that work with me. If they have done work on it, that's great, but it's not official work of my branch or of the fund that's not being created yet. Of course, complementary cover is years down the road. Everybody is very excited about Section 33, but Section 32 is far more important than Section 33 in the first 3 to 6 years of the NHI, because it is the way in which we will go back to how the public sector used to work in 1995 and 1996, before fiscal federalism created 10 departments of health. So we will, there will be phased implementation of many of these anticipated covers, and I wouldn't get too excited about any of that for now. There's no question of decimating private providers. Everybody is well aware that we need every single provider that we can get in the country if we're going to look after all 62 million people in the country. We have 550 billion rand currently being spent annually in the health system. The problem is that a huge portion of that is wasted. As much as 50% we think is wasted in the private sector, and probably as much as 10% is wasted in the public sector. And if we were able to harness that money and get it for private care, I mean for care for all of us, we think we would be in a far better position. Regarding coding, the National Health Council almost a year ago adopted the global coding structures, and we will move towards those coding structures. FISC from the private sector has been intimately involved in this process. And of course, because we are not going to be using fee for service, we will definitely be not be requiring the complicated coding structures that are currently being used across the country. We will use ICD-11, ICHI, ICF, and a whole range of other coding systems that are all mutually compatible, so that we can compare with what we are doing around the world. That will be in the public domain. In fact, it's already in the public domain, but it will be in the Gazette as soon as we get the wording agreed to with the legal advisors of the department. So Rajesh is right. We do want to work, as the Health Market Inquiry recommended, towards performance management. It's a complicated space. And performance management for us is about performance of patient outcomes, not about monitoring what you or I might do on a day-to-day in our practices. And that's a long road for us to get to be able to have the data necessary for us to be able to do that kind of thing. In terms of litigation, there's already discussions with various government departments, including the Department of Justice, on the state law, the State Liability Act, and amendments to the State Liability Act. And the litigation in the public sector is coming down dramatically since we've exposed the lawyers who are defrauding the system. As much as 50% of all current liability against the state is fraud. And the SIU has already started to arrest and suspend. As far as I know, 100 lawyers have, more than 100 lawyers have already lost their licenses because of defrauding the public sector, particularly in the space. And in the private sector, of course, the Law Reform Commission's recommendations will help all of us if we are able to implement them by the time national health insurance comes into effect. But that's quite a long process, and it is being resisted quite a lot by the legal profession. So don't hold your breath on that. In terms of corruption, yes, the public sector has a lot of embarrassing corruption. The private sector has also got quite a lot of fraud, estimated at about 19 to 20 billion rand per annum fraud in the private sector. So between us as the health sector, we've got a lot of cleanup to do. We are working with the Forum on Fraud and Corruption, which is chaired by the SIU, and both public and private sectors participate in that forum. We think by simplifying the system and doing away with 308 options and 71 medical schemes and 9 different provincial departments of health, we will already go a long way to de-risking the health system. But there's lots of work to do in this space, you're quite right. District health authorities are merely administrative structures under the National Health Act, but the district health management officers, which are prescribed in the amendment to the Health Act under Section 31A, which is in Schedule 1 of the National Health Insurance Bill, is a massive departure from district health authorities. They will have far more authority, and they will have very clear mandates that are already outlined in that amendment to the National Health Act. They will not be paying anybody. The National Health Insurance will be paying people, and that will be paid directly to providers. It will not be NASFAS paying anybody, of course. It will be the National Health Insurance. So make sure that when we publish the information in the regulations, that you are all able to comment and be confident that people we are putting on boards and committees are reliable people, and that what we call a fit and proper person will be described in those regulations. Please make sure that you agree with us with those definitions. The last comment that Rajesh made was around trust. So we agree, trust is a massive problem, but if we as South Africans do not deal with our trust of one another and our trust of ourselves, we have ourselves to blame with the systems that we end up with. And I think that if we don't use this framework and this anticipated improved unitary system for us to be able to bring all the budget, all the money, all 550 billion into one national system, and all of us be able to look after all 62 million people in the country, then we can expect to collapse the economy even further, and we can expect no future whatsoever. So I see there are lots of questions, but let me end with those comments, and I'm very happy to answer questions going forward. Thank you.
Thanks, and thanks, Nicholas, very much. Thanks for covering all these questions and responding to what Rajesh had spoken about. We don't have much time, but I'll just cover a few. They're broad. I think we've tried to cover the questions. The first one is mainly around the allied health professionals, allied healthcare professionals feeling that they felt excluded from the process, and because we're told that there's no policy for complementary healthcare. That's one. And secondly, the other allied professionals were saying that there was a pilot program and what are the lessons learned from that pilot, and what can we take from there? But also feeling excluded from the process. That's one. I think there's one about the boards, that you spoke about the boards, that there's nothing that can happen now until we get the boards. But there's a concern that it does look like the Department of Health is abdicating its position and abdicating that part to the boards. And I think it's about when you get into NHI, the infrastructure. Can we get into NHI when there's a big problem with infrastructure currently? You've covered the one about the debt and litigations, that how the health department has got a debt, and what are we going to do that you spoke about SIU investigations, and yeah, I think lastly it's about why don't we, with NHI, why still want to have a unitary system and not have a two-tier system as we have now when you go into NHI? Maybe if you broadly cover those questions.
Okay, thanks very much. So let me start with why not a two-tier system. Why not a two-tier system is because we have a constitution that makes us all equal before the law. And Section 27 is very clear that everybody has a right of access to healthcare. And we are not achieving that because we are concentrating resources, and that includes money and people and skills, in a small portion of the service delivery, and that is not appropriate. So if you read the Constitution and you read Section 27, the answer is very clear. We have a mandate and the minister has a responsibility. And in terms of Section 92 of the Constitution, the minister is accountable for making sure that Section 27 is implemented. It's in the white paper, it's in the previous white paper, it's in the green paper, and I'm really not going to spend a lot of time on it. We must see ourselves as people who need healthcare. We must get healthcare. And it's not acceptable that we choose to give people healthcare just because they've got money. As a public health medicine specialist, for me, that has got nothing to do with politics. It is absolutely crystal clear. If somebody is sick, you help them. In terms of the allieds are not excluded. There's nowhere in the NHI bill that it talks about the nursing profession or the medical profession or the optometrists or the this or the that. Everybody's included. The question is, at what point do we include which benefits? And if chiropractic care or homeopathy is included as a benefit in the first phase or the second phase or as part of primary health care, then that's great. Then it's included. That is something we are well aware of. We will make sure that all rehabilitation workers are included. We will make sure that mental health is included. We make sure that everything is included in the way in which we consider what benefits the fund is able to cover. So do not feel excluded. Keep involved. Keep in touch with us during this process as we move towards appointing a board. In terms of the pilots, so there were 10 pilot districts and a number of interventions were tested over a period of about 10 years. Many of those interventions taught us useful lessons. The most important lesson was that if you try to implement something without a system to back it up, it will fail, even if it's a good idea. So, for instance, the contracting of GPs was piloted, but it was piloted within the context of sessions in public sector hospitals. That's not how the NHI is designed. The NHI is designed as capitation. We don't want to pay people on sessions to go and sit in the outpatient department or in a clinic somewhere. We want to have people staying in their rooms and having patients referred to them as part of a multidisciplinary team within a capitation space. So we learned a whole lot of things about how not to do things, but we did learn quite useful things about how it would be useful, for instance, to have specialist teams on call to be able to back up primary practitioners to answer complicated questions and to refer patients to when you're just a little uncertain and you don't want to burden the patient with a full referral. So there were a whole lot of things. That was published. It's on the Department of Health's website. You can go and have a look at the reports. Some of them are quite negative. Others are very positive. But overall, if you don't amend the system, you will not get the value of the investment. In terms of a board and abdicating, this is a fascinating comment to me because there are comments that have been made in Parliament repeatedly in public submissions to Parliament, including from parties who are on this webinar, that said the minister's got too much power, too much authority, the minister's making decisions. If you spend a little bit of time with constitutional law, you will understand that Section 92 is absolutely crystal clear that we hold the minister of any function appointed by the president jointly and severally liable with cabinet for whatever functions are allocated to them. So the Constitution requires that the minister must be held accountable. But the Constitution is far smarter than that. It says the minister is accountable with the cabinet members to Parliament. And it explains how that is done. In the Public Finance Management Act, it also says that all scheduled entities, whether those are Schedule 2 entities, which are public enterprises, or whether they are Schedule 3A entities, such as this one, which are public entities, national public entities, whether it's any of these entities, it's described that they are accountable to both the minister and to Parliament. So that they have to account to the minister because the budget comes through the vote of the National Treasury to the minister, to the entity, but they are also accountable to Parliament. And all 5 of the current entities of the National Department account directly to the Parliament. And the CEO and the board have to go and sit there and answer questions to Parliament with or without the minister. It's not abdicating responsibility. The law is clear. If you want an autonomous entity that the state and we as citizens have confidence in that they're going to run this fund, then you must give them the accountability and you must give them the tools to be able to do that. You mustn't now come and say the department must interfere and tell them what to do and how to do it and so on. So we need to make a decision. The bill is clear. The fund is a 3A entity. It is autonomous of the Department of Health, and it reports to the Department of Health, the Minister, and to Parliament. In terms of infrastructure, public infrastructure has been underfunded for many years. The big problem is that it is not funded by the Minister, and it's not funded by the National Department, and it's not controlled by the Health Department. Infrastructure management, maintenance, and new infrastructure is largely controlled by public works departments. That's a problem. You can't hold the CEO of a hospital accountable for management if you take the budget away and you put it in a public works department. We have for years argued this case, and we continue to argue this case. And finally, we're getting traction. So at the moment, there's an extensive discussion which was started in 2019 with National Treasury to change the way we manage infrastructure in the health sector. And we believe that once we move into the new environment, in fact, the CEOs of hospitals and other district managers and so on will be held accountable for the budgets that they have for infrastructure management. There's also been a huge discussion over the years about new infrastructure development and licensing. There is no law that authorizes a province at the moment to issue a license. Everything, in my opinion, every license that's been issued since 2001 is illegal. They were issued in terms of Section 44 of Health Act 63 of 1977, and that piece of legislation was abolished and repealed in 2003. And unfortunately, Sections 36 to 40, which were due to replace it, are still a matter before the court. So there's a vacuum, and the only person who has the authority to issue infrastructure licenses is the National Minister of Health. So there are many things that we are going to have to address going forward, and we need a budget to be able to do that. That's a discussion with the Minister, and I'm pleased to say this Minister of Finance is open to the discussions around blended financing and other matters, but that's a subject for a different day. So I think that my last comment is that the health sector is messy. It is not acceptable. We are not servicing the 62 million people in the country effectively. We can do better. And we as medical professionals and other health professionals in the country really need to jack up our socks and work together with us. And we are inviting all of you to be part of the various processes that will be put in place going forward. And we look forward to the bill being passed in the NCOP on Tuesday. Thanks very much.
Thanks, Nicholas. I think we don't have much time. I'm just going to have one question, and that's there was a question for Dr. Mahongasike that was posed by Dr. Rajesh Pillay. How will the HPCSA proactively monitor quality to protect the public? in terms of litigation against the state? And I think that's the last question. Unfortunately, we don't have much time.
No, thank you, Chair. No, we as the Health Professions Council have got access to experts. I mean, just yesterday, for the whole day, I was in a meeting of the South African Council of Medical Deans. So we check quality at educational level, we check quality at delivery level, and we've got academics behind it. So it is not something that will be new. It's something that is done by the Health Professions Council for a number of years. So the fact that there's the NHI coming will not change anything. Standards, norms and standards will still remain. We just have to adjust to the new things of artificial intelligence and so on. But yes, no, we don't. I mean, just on the 25th of November, we had foreign qualified so-called doctors writing exams, and we only have a 28% pass rate. So we're still strict, we keep to it. If you don't know TB, you can't practice in South Africa. It doesn't matter where you were trained, you still have to comply to our standards. So we're still very strict, and nothing will change. We'll continue to be strict to make sure that we protect the public and we guide the profession. Thank you, sir. Thank you, Chair.
Thank you. Thanks very much for that, your comment. Yeah. There's a question by one of the, I think it's just post-ComServe, wanted as a young GP to know where can they find the checklist for accreditation. May I refer you to, I think just go to the website of the Office of the Health Standards Compliance, and I think you might get some information there. And saying that, for HSC, we've got Dr. Ernest Kino. She was the Chief of Operations at Clinix Health Group, but also the chair of the HSC. So I'm going to ask him to do the closing remarks. Dr. Kinoshi.
Thank you very much, Dr. Bila. We'll leave the OHSC out. I'm speaking on behalf of the Clinix Health Group, on behalf of the board of Clinix Health Group and also the group CEO. We'd like to thank the panel of experts that we had today. Dr. Makome Masike, our Registrar CEO of HPCSA, Dr. Nicholas Cripps, the DDG in National Department of Health, who is also responsible and has been responsible, amongst many other things, by the way, for setting up the structure and leading the structure in the Department of Health on NHI. And we also thank Dr. Rajesh Patel from DHF. I think from the questions and from the number of people who attended today, it shows a record 438 attendance of this webinar. It's a record, I say, because it's the highest number we've had since Clinix Health Group started running these webinars, these health care related webinars in the second half of 2020. But this shows the interest in NHI by our practitioners. And I think it also, Dr. Bila, shows that we were right in allocating the November as a month in which we will concentrate on NHI. I mean, the questions raised by Dr. Patel, most of which he had raised when he was in the webinar about 2 weeks ago, I think he led a webinar. Are correct questions, and I think he's been raising questions which are raised by many people amongst our colleagues in the healthcare practitioners, but also among members of the public as well. So those questions are welcome, but I'm happy that Dr. Nicholas Crisp and Dr. Masike were here today to clarify most of the points that Dr. Patel had raised, and I think we should continue to discuss and debate issues on NHI until its implementation and even beyond. I think we should be as open and as possible. And I'm glad that Dr. Chris has told us, which is good news, the latest on NHI and the fact that the NCOP will be voting on Tuesday. I hope they'll vote correctly. We also are glad that he explained the difference between certification and accreditation. And accreditation has been going on in the country for many years. I think he did mention, and Dr. Patel himself is from VHF, which has been accrediting health establishments on behalf of medical aid schemes for years. So it is nothing new in accreditation. I think it is needed. It will just be simplified, as Dr. Crispus has indicated. But also, we thank Dr. Masike for coming from the regulator of most healthcare providers in the country, who are the doctors. We know that there's also pharmacists and nursing council as well for the nurses and pharmacy council. I think we need to indicate that we will also, we are planning, Dr. Bila, if you remember, another webinar where we will invite members of the public now to participate, and we would like to inform them on many healthcare related issues, but especially on NHI. So we may call some of the experts back to in future when we have a webinar, not just for healthcare practitioners or healthcare professionals, but also for members of the public as well. Dr. Bila, let me stop there and hand over to you. I should also thank Dr. How can I forget you for having chaired the session, Dr. Mavengere, a good friend of mine. I think you did it very well. I'm sure this won't be your last session with us. Dr. Bila will contact you again. But I think thank you very much for all the members who, all the audience who participated today. I think we continue to host these webinars simply because you continue to log in. And I'm sure, Dr. Bila, that people are not logging in just to get CPD points with the HPCSA, Dr. Masike, but they want to learn more and contribute as well, because you are free to contribute during the webinar. You can raise your hand when Dr. Bila calls for it, and you can also pose questions during on the chat line during the webinar and after. You can even ask the panel after, either through Clinix or directly. But let me thank also Gamo. Gamo is from our marketing department that does all the background work on these webinars. And of course, you, Dr. Bila, our wonderful webinar master, who's been running this we're going now for the third year. Thank you very much. Over to you to close the session, though.
No, thanks, Dr. Kinoshi, and thanks for those words. Yeah, that's mine is just to say thank you very much, colleagues, for joining us this evening. And Pino, Dr. Mabangera, thank you. We've been running the ship together, and 3 weeks solidly, and we just want to thank you. And we will continue to see each other once more.